This evening, we're going to talk just predominantly about one topic. We're going to skirt around it, but we're going to focus on one main topic. And it's really about the slightly alarming increase in the number of comments that I keep seeing on Twitter, LinkedIn, and also actually in various scientific journals saying that knee arthroscopy doesn't work. And it's really to kind of debunk the myth and to look at this statement in a little bit more detail and to try and work out where this comment has come from, whether it carries any justification, or whether we can actually argue against it. So hopefully this presentation will kind of go through this in a logical fashion and give you, at least, if nothing else, some food for thought. So from my perspective, whenever I'm listening to somebody give a talk, my first thoughts always are, well, who are you? And are you an expert? And why should I actually listen to anything you're saying? Why should I believe it? Why should we give this credibility? So just from my own background, just to you guys, I'm a full-time private knee surgeon, do nothing but knees, and been a consultant for about 12, 13, slightly longer, 14 years, something like that. I've always been into meniscal surgery, meniscal research. I've done that even since I was a trainee. So in round about 2004, I was awarded a Master of Surgery high degree from Imperial College with a thesis on meniscal transplantation. In, I think it was 2003, I think it might have been, I was awarded the Basque President's Medal, and that's the British Association for Surgery of the Knee, the President's Medal, which is awarded annually for my research into meniscal repair. I'm a Hospital Innovations Centre of Excellence for meniscal allograft transplantation. I'm a Vivistat Centre of Excellence for the use of biological glues in knee surgery with meniscal repair. Also founder and past president of the UK Biological Knee Society. So I'm kind of into my meniscal stuff. I've also published quite a few papers and done way too many presentations. So I'd like to think that I've got a fairly good grasp on what's what with the meniscal cartilages. I wouldn't use the word obsessive because that sounds negative, but certainly let's say enthusiastic. So this first picture, this is a little video. This is a meniscal tear. This is what we're talking about. So this is going to be in the knee in somebody in their 30s or possibly 40s. And on an MRI scan, that tear may look relatively innocuous. MRI scans, they're not photos. It's a representation of the water content in the different tissues. So it's not a photo, and it's certainly not dynamic. And when you do an arthroscopy, you're not just looking, but you're looking much more closely, and also you're feeling. So that's that kind of meniscal tear. There's no way that was going to be repairable, and that was a slightly older patient. So they've had a partial meniscectomy. So this is a meniscal trim. So partial meniscectomy. Now, this is the paper that probably kicked off all the fun. This was a review by Thorland. They called it a meta-analysis, but we'll go into this in a little bit more detail a bit later on because I'm going to dissect this. And this was published in the BMJ, that great orthopedic journal, where there's lots of stuff about orthopedics published, not. And so the BMJ published this, and this started off an entire wave of people criticizing and questioning and criticizing the role of arthroscopy. And then we ended up with headlines, headline news from like the Daily Mail. So knee operations are no better than painkillers, according to Andy Carr, that fantastic shoulder surgeon in Oxford who does very little surgery actually, but quite a lot of research about other people's surgery. So interesting comment from him. Interestingly, Andy Carr and I were up against each other directly for a formal debate at the BOTA meeting. That's a British Orthopaedic Trainees Association meeting a couple of years ago. And he lost that debate and I won that debate, which was a little bit reassuring. And it was about the role of knee arthroscopy. And then we had editorials like this in the BMJ saying arthroscopic surgery for knee pain, highly questionable practice. Okay, well, this is where things started to get a little bit ugly, because now we're losing the science, and we're drifting into the realm of sensationalism, the kind of rubbish that you see on Twitter, where people don't give reasoned arguments. It's just it's extreme headlines, either extreme to the left, extreme to the right, but with no real reason. So when I see a headline like this, my first thought is, well, what's an arthroscopy? And that sounds like I'm being a little bit glib, but it's not. It's a really important question. What is an arthroscopy? If somebody said to me, they come to clinic and they said, oh, I've had an arthroscopy, well, immediately my first questions to them are, well, what did they find and what did they do? Because the term arthroscopy to me means pretty much nothing. And the next point is, well, I don't think I've never done a knee arthroscopy for knee pain per se, because knee pain is a symptom, and it's not a diagnosis. You don't treat somebody for a symptom, you treat a diagnosis. So again, this is just, the headline is completely flawed. And then it got even worse. So then we got this fantastic illustrious journal called the British Journal of Sports Medicine, and the number, I don't know why I still sign up to them on Twitter. I'm just torturing myself, because the number of stupid comments that have been tweeted, I don't know who their Twitter editorial team is, but they really should be vetted better. And they're coming out with comments like this: people with a locked knee don't need knee surgery. And it's like, my God, how can you possibly misinterpret the data and misinterpret the literature more and come up with a more stupid and clinically inappropriate and dangerous comment? And this was from the British Journal of Sports Medicine. Really, really upsetting. And then it gets even worse. You've got a company like Regenxx, and they're based in, I can't remember if they're Switzerland now or Belgium. I think they've possibly got branches in both. And they're saying, please don't get meniscus surgery. Come to us instead and have stem cells injected into your knee for only 6,000 to 8,000 euros a shot. And it's, oh no, this is just, now this is getting really, really hard not to get upset. So most knee surgeons are watching this, and this is what they're thinking in their own head. God help me, what's going on here? What's happened to science? So there was a bit of a fight back, and this was a very important paper from Steve Bollen, who's just recently retired, and he was a knee surgeon up north. I think he was Bradford, and he was a fantastic knee surgeon. He was one of the top knee surgeons of his generation. It's a real shame that he's now retired. And I'm going to just take a little step back now, and I'm just going to read, because what Steve Bollen has done is he's analysed the meta-analysis of Thorland, and there's some very, very important points that he's made. So first of all, in the Thorland paper, they started off by looking at 4,000 papers related to meniscal tears or meniscal surgery. Of them, they actually only analysed 1,789, which is fine, from whatever their exclusion criteria were. And of the 1,789 papers they analysed, they actually only looked at the data from 9. Now, of those 9 papers that they studied, that they drew all of their conclusions on, one of those was a trial assessing the contribution of depression and anxiety. I can't say it, sorry. A trial assessing the contribution of depression and anxiety, right, on outcome. Now, I'm absolutely not saying that depression and anxiety are not problems and that are not important. They absolutely are. But that's not one of the main outcome measures that we really would consider as a prime outcome measure after knee surgery. One of the papers specifically related to degenerative change, and one with a placebo arm, which only enrolled 55% of eligible patients. Now that's a massive worry. If 45 of the people who were eligible for the placebo arm of the trial declined, then you've got to ask why they declined, and you've also got to ask, well, what would the results have been if the 45% of people had actually joined the placebo trial, so the placebo wing of the trial. Another important thing, one of the papers that was studied, 56 of their patients had grade 3 to 4 OA. Well, this is not new. It's not a new concept that all of a sudden we found out that knee arthroscopy and washout or debridement is not appropriate for somebody with advanced arthritis. We all knew that, at least those of us who knew anything about knees already knew it. And if there are people out there, and so not if, there were definitely people out there, there were knee surgeons doing arthroscopic washouts in people with arthritic knees. And it's hard to know whether it was stupidity, willful neglect, whether it was dubious practice, whether it was really concerning. Are they just washing things out just for the fee? But it certainly wasn't right practice. But we all knew that. All of us who were even half decent knee surgeons already knew you don't just wash a joint out. That's nonsensical. One of the other papers that was analysed of those 9 by Thorland, they've used highly dubious criteria for surgical intervention. They've relied on MRI diagnosis, which you can't rely on, and just one symptom that might be attributable to a meniscal tear. And that's a quote from their paper. And again, that's deeply inappropriate. In one of the other papers, when they did the surgery, the meniscal tear was addressed, but 70% of the patients had significant degenerative change at arthroscopy, and the symptoms from the meniscal tear were unlikely to have been attributed solely to the meniscus. So again, highly, highly dubious. Another one of the papers, this is Katz now, the Katz paper reviewed by Thorland. Of the 150 patients in the physical therapy group, 51 of those 150, 1/3, had crossed over to the surgery group within the first 6 months, and a further 8 did so within 6 to 12 months. Now that's a terribly, terribly important stat. And I think that's probably, we'll come back to that, but that's probably one of the most useful statements within the whole of the Thorland paper. So it's worth going back and looking at this paper from Bollen, because Bollen does a really high quality analysis of the Thorland meta-analysis, and he completely rips it to shreds. And yet, when Steve Bollen tried to get his paper published by the BMJ, it was rejected. So Steve Bollen wrote a letter to the BMJ and asked just for the letter to be published, and it was rejected. So this is really upsetting and really worrying, because the BMJ seemed to be biased against surgery and biased towards sensationalist headlines with dubious, if any, science behind them. And that's a real concern. So Steve Bollen had this paper that you're looking at now published in the Bone and Joint Journal, and he had his letter that was rejected published in the Journal of Arthroscopy. But problem is that those are niche specialist journals that most people wouldn't have read. So in response, the British Association for Surgery of the Knee set up a consensus group, and they've published this fantastic guideline. And this was again published in the Bone and Joint Journal just last year. And so I would strongly advise people to read this, because these are the definitive professional guidelines on the management of meniscal tears and arthroscopy in terms of arthroscopic partial meniscectomy. And basically they've produced a very sensible, very basic, but very easy to follow pathway. So just to go through this briefly, if you've got a locked knee, you're going to need an urgent arthroscopy. If you've got an acute injury and a meniscal target, in other words, you're fairly certain that there's a meniscal tear, then, meniscal preservation may be appropriate, which means you might be trying to do a meniscal repair, then arthroscopy and try meniscal repair. If you've got a meniscal target with symptoms and signs, well, this is where it gets interesting. Symptoms for more than 3 months, we'll consider arthroscopy. Symptoms less than 3 months, well, conservative management. I saw a very interesting Twitter, I think it was either today or yesterday, from a physio colleague, and there was a discussion about whether meniscectomy causes arthritis. And his response was, this proves that we need aggressive rehab for meniscal tears. And we'll come back to that point, because that was slightly worried me. But if you've got advanced OA, so you've got grade 3 or definitely grade 4 arthritis. And also, if you've got symptoms and signs that don't sound particularly meniscal, and we'll come back to that point, then actually conservative management. So there is strong evidence to back up these guidelines. And as we said, even if you want to be pessimistic or maybe realistic about this, of the 150 patients in the physical therapy group in Katz's study, then 51 followed by a further 6, so 157, sorry, 57 out of 150, so a third end up needing surgery. So you could argue that in this group here, in the middle group, in group 3, then it's maybe 1/3 will end up going for surgery and 2/3 might not. And we'll come back to that point as well. So this is just a little kind of mind map about how I'm thinking when somebody comes to see me. And these are the points that I am mulling through my mind when it comes to decision making. So first of all, are their symptoms severe? Well, if they've got severe symptoms, well, you're more likely to go to surgery. If their symptoms are minor, you're more likely to manage it conservatively. Are their symptoms getting better? Well, if they're getting better, then wait. That's not rocket science. For as long as somebody's symptoms are improving, then be patient, wait and see what happens. And if their symptoms are coming down, 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 and they disappear to 0, well, great, there's no debate. Leave them alone. If their symptoms come down and plateau here, well, then the question is, where's their threshold? If their threshold for getting something done is here and the symptoms end up going below that, then you're going to leave it alone and manage it conservatively. If the symptoms plateau here, then, and their threshold for what they can tolerate, which is a very arbitrary concept, is here, then you're going to operate. If their symptoms are not getting better, or if their symptoms are getting worse, then you're more likely to operate. So time is time in many circumstances is really useful here, not in all, and again, we'll come back to that. But in a majority of circumstances with a meniscal tear, certainly in older people, then time is your friend, because when you wait, the answer, the correct answer reveals itself. It becomes increasingly obvious as to what category they're in, wait or operate. Next, mechanical symptoms. And you have to be very careful because there's a good paper from, I think it was Roos, certainly one of the Scandinavian groups, that showed that patients' understanding of what a mechanical symptom really is not very good. So if you say, have you got any mechanical symptoms to a normal person, they're going to go, what the hell are you talking about? I have no idea what you mean. If you say, oh, have you any locking? They go, oh yeah, kind of, yeah. Well, again, locking is not an everyday term. People are not going to understand that necessarily. It's not enough to say, does your knee lock? You've got to explain what you mean, because a lot of people say, oh yeah, it gets kind of a bit jars, or it gets a bit sticky, or it catches and clicks a little. No. So you explain to them, you say, if this is your knee, do you ever get an episode where you try and straighten your knee out and it gets stuck in one point, and then you wiggle it and there's a bit of a clunk and it straightens out? That's proper locking. And they go, oh no, I don't get that. But if you say, well, does it lock a bit? They might say, well, yeah, it kind of does a bit. You have to be very, very specific in your question if you want to ensure that you get the correct answer back. Likewise, if you say, does your knee give way? Well, there's different types of giving way, because again, that's not a normal concept that most people will be able to answer easily. So what I say is, does it ever give way? And they go, and straight away you jump in and say, by that, what I mean is you put your weight on it, and there may be a sudden pain and it just suddenly gives and you feel like it's gonna go and you're gonna fall. And they may say yes or no. And if they say yes, well, does it happen once in a blue moon, or does it happen often? How many times a day or how many times a week? You've got to quantify it. Does it actually give way? Do you fall, or does it just feel like you might? When does it happen? Is it when you twist on your knee? Is it coming down the stairs? You know, there's a load more questions to ask other than, does it give way? Having said that, generally speaking, if you want to be simplistic about it and you say any mechanical symptoms like locking or giving way, yes, you're more likely to go for surgery. No, you're more likely to opt for conservative. And you know, you've got to listen carefully to the wording that I'm using here. I'm saying more likely to opt for, right, or less likely. I'm not saying yes, you need surgery, no, you don't, based on such a simplistic, yes or no answer. And then this one is really important. Meniscal pain. I would say that meniscal pain is a sudden, sharp pain when you put your knee in certain positions, like forced deep flexion, for example, if you're kneeling on the floor and you try and sit back with your bum on your heels, or if you twist on your knee, or if you cross your leg over. So you cross one leg over the other. And you get a sudden, sharp pain. And if you do, well, where is that pain? Is it at the front? Well, that might be patellofemoral or patellar tendon, or is it medial or lateral or posterior? Remembering that a lot of meniscal pain is felt posteriorly. And if that doesn't kind of make sense, then again, sorry, the reason God gave me an elbow is simply to mimic what the knee does. So you've got your meniscus, your little C-shaped wedge, where your meniscus sits in here, and my thumb is now in the crook of my elbow. And when you bend your knee, you pinch the back of the meniscus. And the most common place to have a meniscal tear is the posterior horn. Hence, pain posteriorly with forced deep flexion is quite a reliable sign of meniscal pathology. Or is the patient's pain more of a constant, deep, dull, achy, nauseating pain, particularly if you go on long walks or towards the end of the day if you've been on your feet for a long time? Well, if you ask that and they say yes, well, that's not meniscal pain. That's more arthritic-y pain. It's more like a degenerative knee. So you've got to know, it's not enough to say, does your knee hurt? You've got to ask about the pain. You've got to try and characterize it. So does your pain sound meniscal? Well, then you might think about surgery. Or does it sound more arthritic-y, more degenerative? Well, then if all you've got is pressure overload in your subchondral bone because of thinning of the articular cartilage, or even worse, loss of the articular cartilage, then is an arthroscopy going to help that? No, of course not. Right, but that's not rocket science. We all knew that. Advanced OA, easy. Almost certainly manage it conservatively or with a knee replacement, but not with a washout. Right? Washing out synovial fluid and a bit of debris is just stupid. Guy called Dick Steadman, who's quite famous. He's the guy who popularized microfracture, and he's in Vale at Steadman's Hawkins Clinic. I think he might have retired now. He published quite a good study about 3 or 4 years ago, where he took people who'd been referred to him for a knee replacement, and instead of doing a knee replacement, in a cohort of them, so it was his select group, he did an arthroscopy and a debridement. So that's a tidy up. And some people take the mickey out of the term arthroscopic tidy up, but I don't, because it's kind of a very non-descriptive catch-all phrase that says you're going to trim and smooth off and stabilize any meniscal tears. You're going to smooth off and stabilize any unstable articular cartilage surfaces or edges. You're going to remove any loose bodies. You're going to tidy away any thickened, inflamed synovial or plical tissue. There's a lot you can do to tidy up a knee. So tidy up is a perfectly fair phrase to use as a catch-all. But the worse the knee, the less likely it is that a tidy up will help. And the best analogy there, and sometimes analogies are quite useful to explain things to patients. Let's say you've got a shed, right, and it's painted, and the paint's getting a bit flaky and it's getting a bit old. Well, yeah, you can give it a lick of paint and it may last a few more years. If you've got a shed that's completely rotten, the paint's flaked away, then the wood is just soft and falling apart, well, your lick of paint is going to do sweet FA. So it's a little bit like that with a knee. If you've got a knee with not much wrong with it, there's no point in doing an arthroscopy. If you've got a knee with yay much, that's an arbitrary yay much wrong with it, then there's a good chance that you'll be able to have a good effect. It'll be worthwhile bothering. If you've got a knee that's completely knackered, then no, you've missed the boat. So our focus should be on identifying those people in the middle who are within the realms, within the boundary of what's actually reasonable. And then again, well, have you ever met a meniscus in clinic? I don't think I have, but I've met lots of people who've got a meniscus. If they're lucky, they got 4. But we're not talking about a meniscus. We're not even talking about a knee. We're talking about a person. The meniscus is in a knee that's attached to a person, and every person's different. So if you've got somebody, and again, let's talk extremes just to demonstrate the point. If you've got somebody who's a complete one end of the spectrum, they're 90 years old, they can't walk, they're in a chair, they're hoisted from chair to bed, and they're in a nursing home. Are you going to do an arthroscopy on them? Of course you're not. Other end of the extreme, you've got an 18-year-old academy football player whose entire career is ahead of him, who, an entire career of professional football. If they have a meniscal tear, are you going to have to operate? Well, very, very, very likely. So who are you dealing with, right? And do any of these papers, like Thorland's paper and all the other papers, no, they deal with cohorts, they deal with groups of people. And you've got to be so careful with this concept of a meta-analysis, as if the meta-analysis is a Bible of science. It's not. Best way you can get that point across is if you think about flowers, and this is a little bit puerile, but think about flowers, right? Well, a study may say that there are red flowers. Another study may say there are blue flowers. Another study may say there are pink flowers. And a meta-analysis will put them all together and tell you that all flowers are great. Right? That's just a concept, all right? I know it's trivializing it a little bit, but it's just a concept to be wary of. So, ought to get back on point, shouldn't I? Right, if the patient is young and sporty, then yes, you're more likely to operate. If they're old and cruddy like me, no, you're probably not going to operate. And then, have you, as a clinician, I assume that everybody who's listening is clinical and everybody has done at least a little bit of training, then have you got a brain? And if not, then protocols and guidelines are very, very useful for you, right? And if you've got no brain, we've got a fair way of putting this is, rather than being facetious, all right? If you've got no experience, let's change it to that, let's make it more polite. If you've got no experience, then protocols and guidelines are really, really good, because it means that you're safe to the patient. You're not going to go too far off track. But if you've got experience, and if it's an area that you've got some expertise or specialist interest in, then professional judgment, it's about interpretation, right? Applying the rules appropriately to the individual who's sitting in front of you. And that's very important. Going back to the Basque professional guidelines document, if you look down the bottom here, very important little bit, and it says, NB, note well, patient treatment preferences must always be considered. I love that line, just considered. So if the patient says no, you can still operate? I don't think so. I think they're kind of paramount, really, as long as the patient doesn't ask you to do something inappropriate. This guideline document should support, not substitute for, shared decision-making. And unfortunately, that was in a little box at the bottom. And it's an incredibly important statement. So, a few little points now. What's an arthroscopy? All right, well, I can tell you what an arthroscopy is. It's the technique for looking inside a knee with a camera. All right? Or you could also say it's a surgical approach. All right? Is it a diagnosis? No. Is it an actual procedure? No. Unless you're doing a diagnostic arthroscopy, but then a diagnostic arthroscopy is something I find a really, really uncomfortable concept. For me, an arthroscopy is where you've got a pretty good idea about what the diagnosis is, or you may have a small shortlist, a small differential diagnosis, but you pretty much know what you're expecting to find, but you may find something different. You've always got to be ready for that. Right? MRI scans, you can never rely on them, and you can also never rely 100% on clinical diagnosis either. So you kind of know what you're expecting to find, but you know that you might be wrong. But you're going in there to find something and to do something, in which case it's not a diagnostic arthroscopy, it's a therapeutic arthroscopy. So what's a diagnostic arthroscopy? Well, diagnostic means that you look inside and either A, you find nothing wrong, in which case, well, what are you doing in there? You shouldn't have been in there in the first place. Or number two, you found something that you can't deal with, in which case, well, you're not up to the job. You shouldn't have been going in there in the first place. If you're not capable of doing a meniscal repair, well, don't do a diagnostic arthroscopy in the knee of somebody who's young. I mean, that's just silly, right? Because then they're going to need another operation for somebody who can do the meniscal repair, and that's just completely unnecessary surgery. So diagnostic arthroscopy for me is a bit of an anathema, really. So apart from that, an arthroscopy is simply a surgical approach for looking inside a knee. It tells me nothing more than that. Sorry to labour the point a little bit, but you guys who are physiotherapists, you must relate to this. You must, because I know that you guys get people turning up for treatments with you post-operatively, and they say, yeah, I've come from post-op rehab, and you say, what have you had done? And they go, an arthroscopy, and you go, what did they find? What did they do? And they go, I don't know. and you say, have you got the notes? No. Have you got the video? No. You know, and you're hamstrung because you don't know what rehab to do. So that's the point. So what can actually be done inside a knee arthroscopically? All right. Well, you can do a partial meniscectomy. But again, what's a partial meniscectomy? You've got to be really careful with all these papers that talk about the consequences of partial meniscectomy or the outcomes from meniscal surgery. Well, if somebody says to me, I've had a partial meniscectomy, immediately I'm thinking, have you now? Is it 1% or 99%? Is the peripheral rim intact? Is it not? Is there a segmental defect? I always ask people, have you got the arthroscopy photos, or have you got the video from the arthroscopy? So can I actually see what they did? And that's the gold standard. You know, I video every single arthroscopy that I do, and I give the patient a copy, and it's not just the static pictures, it's the actual video clips as well. And I video lots and lots of little separate clips showing all the relevant bits of what's found and what's done. So even a partial meniscectomy as a term means almost nothing to me. Is it 1% trim? Is it a 99% trim? Is it just the inner free margin? Is it a full width segmental defect where you've got a discontinuity in the peripheral rim? You know, lots and lots of questions. Meniscal repair. So if you can repair it, repair it. And then if you're lucky, you would have restored the function back to the meniscus, or at least some of the function. But you can also do radiofrequency coablation and chondroplasty, and that's with a little welding tool that smooths off and stabilized rough or unstable edges. And that's a really, really valuable tool. It's so important that I've got one of these actually not just available, but open for every single arthroscopy that I do. I use it in every single scope, even if not for smoothing things off. The other use for it, there's 2 buttons on it, is for coagulation, to seal little blood vessels. And that's really important. And that's why I don't use tourniquets for any of my arthroscopies, because if you're going to make something bleed, you want to see it, you want to coagulate it and stop it. You don't want a knee that fills up with blood at the end of the operation, but you don't know about it because there was a tourniquet on. Removal of debris, removal of loose bodies, that's fantastic fun. You're not supposed to say that, are you? But, you know, people go to fairgrounds, don't they? And go on those machines, the grabby thing, and goes, boom, and it picks up something. Well, you get that kind of feeling when you get a nice loose body and you take it out the knee. Something really tangible and solid to do. Excision of plicae, synovectomy, biopsy, arthrolysis of scar tissue. Well, ACL reconstruction, that's arthroscopic. Meniscal transplantation, that's arthroscopic. Articular cartilage grafting, sometimes open, sometimes arthroscopic. Really difficult arthroscopically, but sometimes doable. And if I'm doing, I think the hardest arthroscopic procedure that I could possibly do or do is something like a revision ACL reconstruction with a meniscal transplant with an articular cartilage graft. And the Americans refer to that as a biological knee replacement. And that's going to take me, if I do all of that all in one go, it's going to take me 4 hours, sometimes 4.5 hours. Well, hold on, that's a knee arthroscopy. But hold on, knee arthroscopy doesn't work, does it? If you believe the headlines. All right, so can you see where I'm coming from in terms of what is a knee arthroscopy? So now a little bit about meniscal repair. This is somebody who's actually young, they've torn their ACL and they've got a bucket handle tear of their medial meniscus, and the whole thing's flicking forwards. The reason there's such a big gap there, right, between the femoral condyle and the tibia is that I've pie crusted the MCL, and pie crusting the MCL allows the medial compartment to open up a bit, only by about 3 to 5 millimeters, but that makes all the difference in terms of getting in there and being able to see what you're doing. And then that's what the meniscus looks like after it's been repaired. Now, I don't think anybody would hesitate to say that's not quite normal. So please don't think that just because a meniscus has been repaired, that you've got a perfectly normal meniscus. You haven't. Right? First of all, there's evidence to suggest that actually in most most meniscal tears, there is some degree of degeneration, pre-existing degeneration within the meniscal tissue. Secondly, the only tissue in the body that heals up without scar tissue is bone, right? Because bone fully remodels, right? Every other tissue, liver, skin, you can see it obviously on a skin, heals with scar tissue. The meniscus heals with scar tissue as well. So please don't think that a meniscus is perfectly normal just because it's been repaired, even if it heals. And then what we're doing here is I'm injecting PRF, platelet-rich fibrin. So this is from this is Vivastat PRF. It's a biological glue. So we take 120 mils of the patient's blood, we spin it down, we get the fibrin, which is the sticky part of the blood clot, mixed in with an 8 times concentration of platelets, and it comes to about 5 mils, and we inject it and smother the repair. And what it does is it releases growth factors over the course of the first 7 days. This is not PRP, right? This is very, very different. This is PRF, platelet-rich fibrin, autologous bioactive biological glue for meniscal augmentation. Sorry, for meniscal repair augmentation. But if you want to do a meniscal repair, then really you want a young patient, and the oldest patient I've done a meniscal repair in was 64, I think he was, and he was a runner who was incredibly fit, and his knee was absolutely pristine, and he had a vertical circumferential peripheral tear, and his meniscus did not look at all degenerate, did not feel degenerate. Repaired it and it healed, but that was an anomaly. I mean, that's an outlier. Normally, the definition of young is you become less young from 40 onwards, is maybe a polite way to put it. All right, so it's a very arbitrary concept. Some people even say, as far as the meniscus is concerned, that you're only young up to the age of 35, but I don't really agree with that. And yet, at the same time, I've definitely seen a small cohort of young people with very premature degenerative tears in the posterior horn of the medial meniscus in as young as 20. So that's young is very, very arbitrary. The ideal tear to repair is a vertical peripheral circumferential tear, A, because it's in the part of the meniscus, the red zone, that's got the best blood supply, so it's most likely to heal, but also B, the circumferential fibers of the meniscus have not been interrupted like they are with a radial tear, and therefore that meniscal tissue is actually still functional if you can get it to heal back in place. And C, these tend to happen at the edge of the meniscus. So if you do a meniscectomy, you're doing a subtotal or even a total meniscectomy. So the consequences of meniscectomy for a vertical peripheral circumferential tear are equivalent to a total meniscectomy, which is obviously more severe. And then there's no point in trying to stitch a meniscus if it is degenerate. If it's degenerate, then that's probably why it's torn. Right? And degenerate meniscal tears, 50% of them occur with no history of any trauma at all. So the meniscus has just got degenerate, weaker, poor blood supply, and what happens is it becomes soft, friable, degenerate, loses its elasticity, and it's more easy to tear. Even if you put stitches in a degenerate meniscal tear, it's probably not going to heal. And you're probably going to end up having to go back in there and just trim it anyway. So if you have a degenerate meniscus, you tend not to repair them, although there are a few exceptions to every rule. And then very importantly, if they're caught early, and this is a terribly, terribly important point in this era of people saying that arthroscopy doesn't work and meniscal tears can be rehabbed aggressively, statements like that. If you've got a young person, if they're young, sporty, active, they've got a traumatic meniscal tear, and it's a significant, and I'm not going to define it any more than that, let's say a significant tear in terms of the severity of the tear and the symptoms, then treat it surgically, treat it early. The earlier you catch it, the less damage there's likely to be to the meniscus, so it's less likely to propagate the tear, and the more likely it is to be repairable. So those are the ones to catch early. So just going to end up with a couple of little examples. So this is the knee of a 57-year-old man, but he may be 57, but he's incredibly fit and healthy. He swims, plays tennis, plays squash, plays polo. And 18 months ago, he was simply crossing his right leg over his left leg when he felt something happen in his knee, and then he couldn't straighten his knee. And this is his knee. So, sorry, let me go back. So this is his knee. Medial, lateral, right knee. So here we've got the medial meniscus, here we've got the lateral meniscus, but there's something funny sitting here. And there you can see there's a lump of meniscal tissue, and the lateral meniscus is smaller than it should be. So what we've got here is an absolutely classic displaced, locked bucket handle tear of the lateral meniscus, and coincidentally a degenerative horizontal cleavage tear in the body and posterior horn of the medial meniscus. Looking at the sagittal views, here you can see that lateral meniscus posterior horn is smaller than it should be. It should be filling this gap. Why? Because it's flipped forwards and into the intercondylar notch and anteriorly. And there's a tiny, tiny, tiny little bit of articular cartilage damage there, just a millimetre, right? So you're probably thinking that's not a big deal, just a little millimetre of damage, a little bit of subchondral bone edema, but not that bad. There's the ACL. There's part of the lateral meniscal fragment. There's the PCL, that looks fine. And here's the medial meniscus with that horizontal degenerative cleavage there. And this is an acute episode because you see there's an effusion in the knee, which is a sign that it's all fresh. So 18 months later, he didn't come to see me when he did it. He came to see me 18 months later with a fresh MRI scan and a knee that's painful and a knee that still doesn't extend. In other words, he's had a locked knee for 18 months. So this is his recent MRI scan. Now, first of all, look at the medial side. Look, there's that horizontal degenerative cleavage tear in the medial meniscus. Hasn't changed at all, right? Hasn't changed at all. Really important point, that point. Hopefully you guys can still see me. Am I on your screen? Yeah, right. If you've got a horizontal tear and you load it, then it tends to be inherently mechanically stable. If you have a vertical tear and you load it, then they're the ones that tend to split apart and be A, more symptomatic, sudden sharp pains, and also B, propagate, and C, in other words, get worse, and C, be unstable, in other words, causing mechanical symptoms they're catching. So, really interesting point. That meniscal tear, that degenerative horizontal cleavage tear in the medial meniscus hasn't changed at all in the last 18 months. This side of his knee, the lateral side, well, unfortunately, that hasn't changed. The meniscus hasn't changed in 18 months. He's still got a displaced locked bucket handle tear, but look at his poor little ACL is being tented. So the ACL is now being tented by that fragment that's been sitting there. But unfortunately, it gets more worrying than that. If you look at the articular cartilage now, the articular cartilage on the lateral tibial plateau, which previously, just 18 months ago, looked fine, is now extremely thin. And if you go to the sagittal views, all of a sudden we see, hold on, you've got an area of articular cartilage loss on the main weight-bearing surface of the lateral femoral condyle that's probably either down to or virtually down to bare bone on this surface here, which is the surface that would be maximally loaded with the knee at about 30 to 45 degrees of flexion. And his ACL now is looking extremely pale. And the reason it's looking pale is because it's become degenerate, because it's being pressed on by that big fragment. Whereas in the medial compartment, articular cartilage still looks exactly the same as it was, and you've still got that horizontal tear. So is arthroscopy completely useless? Well, absolutely, obviously not. All right. Does every meniscal tear need surgery? Absolutely, obviously not. Can you lump all meniscal tears in together? No, only if you're stupid. Unfortunately, that's what a lot of these papers have done. And is it fair to exclude patients from having arthroscopic surgery just on the basis of one or two slightly misguided papers? Well, the answer is absolutely not. Nearly at the end now. This is a paper from Steve Bollen again, and this is Steve Bollen's final publication before he retired. And that's a generous picture. That's quite an old picture of Steve, all right? But he was a fantastic surgeon and a fantastic bloke. And I won't ask you to read this whole thing, but what he's basically saying is, if you want to blame anybody about the comments that have appeared and the misunderstanding about the role of arthroscopy and about the way that insurance companies or PCTs or CCGs have tried to exclude people from having access to arthroscopic surgery, then if you want to lay the blame, the first blame needs to be laid firmly and squarely at the feet of those surgeons who abused their position by operating on people for either poor indications or the wrong the wrong indications, and for doing arthroscopic washouts in people with arthritic knees, which was nothing other than poor practice. So if you want to blame anybody, what Steve is saying is blame yourselves. The people who've made the biggest mistake here is actually the knee surgeons. And there's a lot of validity in what he said. There's a question for a little bit of debate. Does meniscectomy cause arthritis? Well, again, what meniscectomy? I mean, what kind of meniscal tear? Partial meniscectomy, so how much? This is a massively oversimplified question. There's so much more to it than that. We can debate this at length, but it's complicated, and that's a massively simplistic question. So in summary, management of meniscal tears and the role of knee arthroscopy. All right, if you're confused and if you're thinking, well, does this patient need surgery? Sorry, might this patient need surgery, or do they not need surgery? Well, if that little man is me on the screen, then I'm thinking, well, how old is my patient? What's their job? Is it a physical job, a manual job? Is it a desk job? Do they play any sport? And if so, what sport? At what level? What are their aspirations? Do they want to carry on playing sport, or have they reached the end of their line? Are they happy to be a little bit more sedentary, or do they want to walk, climb Kilimanjaro or do an ultra marathon next year? How severe are their symptoms? You can't just talk about pain. If I stop talking, stop presenting, and actually just start thinking about my own body, I probably start to feel the pain that I quite often get in my right knee, my left hip, my left sacroiliac joint, my neck, my left wrist, etc. Every single one of those is true, right? Just don't think about them because none of them are severe. So what are the severity of the symptoms? Are there mechanical symptoms? What about the functional restrictions? You may have some pain, but so what? If it doesn't affect you, you may be able to just carry on. Think about the tear. What kind of tear is it? Is it a stable horizontal cleavage tear? Or is it a radial tear? Is it a circumferential tear, a bucket handle tear, a flap tear? There's lots and lots of different ways of describing these tears. Is there meniscal degeneration? The more degenerate the meniscus is, the less likely you are, well, by far, the less likely you are to be able to repair it, and therefore the less inclined you should be to do an arthroscopy, unless the symptoms are bad enough to justify it. And what's the state of the knee? Is it fully arthritic? Is it somebody who just needs a knee replacement sooner or later? In which case, don't do it. And then when did they injure their knee, or when did their symptoms come on? Has it been a long time or a little time? Are their symptoms getting better with time or worse with time? Are they fit for surgery? Are they capable of doing the rehab required after the surgery that you're thinking about? And then we're back to the final statement from the BASC guidelines. Guidelines should support, not substitute for, shared decision making. So all of these bubbles are what I'm thinking when somebody talks to me about a meniscal tear. And what's most important? Him or her, the person in the middle, all right? The person who's actually got the meniscal tear. So our job is to guide people. Right? People say to me, oh, when do you do an ACL reconstruction? Well, that's really easy, right? Number one, when somebody's actually torn their ACL. Right? Number two, if they need it. In other words, if they've got a wobbly, functionally unstable knee and they want to do cutting and pivoting maneuvers, right? If they need it, right? And number three, if they want it. People kind of tend to forget that, particularly in all these papers, right? People actually kind of have a right to and do actually make their own decisions about what they may or may not want. And our job is not to paternalistically kind of grab people and force them to have surgery. Our job is to give people the options, the pros and the cons, and let them make the right decision for them. But our job is simply to get a correct diagnosis, first and foremost, and then discuss with the patient the pros and the cons, the positives, the negatives, the risks, the rehab of whatever surgery may or may not be a potential option. Right? It's not to dictate to the patient. And then the decision is simply weighing up the pros and cons. Simple as that. All right. The pros of trying to make somebody better against the risks of potentially making them worse. And every single thing that I do in surgery, in fact, with every single patient, it's always get a diagnosis, and that's the key thing. Then talk through the treatment options, and then help the patient, guide them and assist them with a risk-benefit analysis for all the different treatment options available before the patient then potentially comes to any kind of conclusion or decision. So it's really about clinical judgment. And this is easy, it's what we all were trained and programmed to do from day one at medical school or physiotherapy school, whichever area you've trained in. Do the right thing for the right patient at the right time for the right reason, right? It's simple. It's called good medicine, all right? It's nothing that complicated.